here's a picture of the organ we're going to be talking about today, the colon and the rectum, 1.5 meters of large intestine. And I've put down the division of cancers on the right and left side and the rectum. So about 40% of colorectal cancer cases happens on the right side, about 30% on the left side, and 30% in the rectum. And in terms of risk factors, we will be talking about the colon and the rectum together, but in terms of management, it's a little bit different from rectal cancer. So, I will mainly be focusing on colon cancer management today. So here's the worldwide incidence. So we see about 1.2 million new cases in the world every year, with about 600,000 deaths, making this the third most common cancer in the world. And the fourth most common cause of cancer death. Now, as you can see from the map, this cancer is strongly associated with a Western lifestyle, with incidences ranging from a low of 5 cases per 100,000 in some countries in Africa, and up to over 40 in some of our Westernized countries. Now, in some countries, the cancer incidence has started going down, and that's mostly in countries that are now doing screening for this cancer. So this is the United States as an example, where you can see the incidence in males on the left and females on the right. And you want to focus on the blue line, which is colorectal cancer. And so it was back in the 1970s that we got the first reports that colonoscopies might be able to detect polyps and cancers early. And in the 1990s, colonoscopies became readily available. And in the 2000s, Medicare, our program that ensures our older population, started covering colonoscopies. And as you can see, the incidence rates have steadily declined in the United States. And today, over half of our population older than 50 are getting some kind of screening for this cancer. Colorectal cancer mortality has also declined in most countries. And we think that this is mostly due to our therapies that have improved, particularly over the last 10 to 15 years. I will go into a little later. And just to show you an example of the lifetime risk of developing this cancer. So in the United States, our lifetime risks are between 4 and 5%. And here it's divided by age. And as you can see, this is really a cancer of the older population. For someone who is under 50, the likelihood of getting a colorectal cancer under 50 is 0.3%. But when you're 70 or older, it's 3.5, 3.2 or 3.5% in females and males. And from birth to death, almost 5% in this country. Now, of course, most colorectal cancers are sporadic, meaning they're happening in our average risk population, related to some risk factors, but often we can't really pinpoint what caused them. But then in up to a third of people, there is some family history of this cancer. And in part of those people, we find an inherited cancer syndrome. So we said about 4 to 5% of colorectal cancer is due to an inherited cancer syndrome, with the most common of these being Lynch syndrome. And if we look at these cancer syndromes in a little more detail, today we know exactly what genes are mutated in each of these cancer syndromes. And by far the most common is Lynch syndrome, where you can have mutations in one of 4 genes in a DNA repair system. And if you carry a mutation, that significantly increases your absolute risk, particularly the MLH1 and MSH2 genes. Now, These syndromes, these are the polyposis syndromes, meaning these are individuals that can develop hundreds and even thousands of polyps in the colon. And some of them are very, very strongly associated with developing colon cancer, and often by the age of 20 in the instance of FAP. Now, while colorectal cancer has been going down in our older population, there have been some concerning trends in our younger population. And again, these are numbers from the United States, with people under 50 seeing a rise in the incidence by about 2% per year of colon cancer and up to 4% of rectal cancer. And so if we're looking at a birth cohort and comparing people who were born in the 1980s to someone who was born in 1949, people who are born in the 1980s are about 2 to 4-fold more likely to get colon or rectal cancer than our older birth cohorts. And this has caught the attention of the media, and we're trying to educate our general population that for younger people, if they have concerning symptoms, to go seek medical advice and have a diagnostic colonoscopy. And we'll talk a little bit later about symptoms. And so we know pretty well how these cancers form, that they go through what we call the adenoma carcinoma sequence, meaning we start with someone who just has normal epithelium in the colon, and then something happens. You often starts with a mutation in APC, and we get a small adenoma. It's still a benign polyp. Some additional mutations in RAS, so adenoma grows larger, and then finally becomes invasive. And so this is sort of the model disease where you really want to be able to go in and snatch out those polyps before they become cancer. And we of course know that not all polyps lead to cancer. It's really the adenomas that we worry about, particularly when they grow large, over a centimeter, or if they have these tubulovillous or villous features or high-grade dysplasia. Or hyperplastic polyps do not turn into cancer, and these serrated polyps, which we know a little bit less about, they're sort of more recently described, can be associated with these MSI high cancers that we'll talk about. And we know well that if we do take out those polyps, it can really reduce the colorectal incidence and colorectal cancer mortality. So if we look at the different risk categories and how we would screen someone here in the United States, we've already talked about that the lifetime risk here is about 4 to 5%. And so for someone who's older than 50, we recommend starting screening. This could be a colonoscopy or could be one of several different methods that we'll go through. Then we have our modifiable risk factors. Each one of them will increase the lifetime risk slightly, but does not change the screening guidelines, meaning we still start at age 50. And then we have the risk factors that we can't really change. People who are born with an inherited cancer syndrome, or have inflammatory bowel disease, or have a family history with a first-degree relative with colon cancer under 60, or a personal history of cancer. They've already had a colon cancer. And that increases the risk, the lifetime risk, significantly. And so that changes screening guidelines depending on exactly what risk factor you have.